Thank you all for joining the session addressing side effects in patients with breast cancer. We are excited to have a really amazing panel today. I will be moderating. I'm Dr. Jennifer Klemp. I'm from the University of Kansas Cancer Center, where I'm a professor of medicine in the Division of Medical Oncology and our Director of Cancer Survivorship. I'm going to let each of our distinguished panelists introduce themselves, starting with Dr. Mirabeau-Beale.
Hi, so I'm Dr. Kristina Mirabeau-Beale. I'm a board-certified radiation oncologist practicing in Fort Myers, Florida, with Genesis Care USA. I'm also the director of our breast cancer leadership program at our regional cancer center.
Great. And
Hello.
Mayra.
I'm Mayra Lima. I'm a nurse practitioner here at the University of Miami Sylvester Cancer Center.
Great. And Dr. Rojas.
I'm Dr. Kristin Rojas. I'm a breast surgeon at the University of Miami. I'm also a board-certified gynecologist and the director of the Menopause, Urogenital, Sexual Health, and Intimacy Clinic here at University of Miami.
So as you can all see, we have a great group to discuss really some common issues in our patients with breast cancer and some strategies and other sort of alternatives as we manage our patients and think about whole person care. So starting out tonight, we just kind of want to right size what are the objectives for the session. And that will be to identify opportunities for symptom management of common survivorship issues, think about those common late effects, and sort of put them into perspective. One of the most important parts about how we need to think about survivorship is really using risk stratification for our patients. What are the most common issues that our patients will experience, but then based on the patient presenting their comorbid conditions, their priorities, how do we help really take those priorities and help build some strategies either to improve or hopefully resolve some of those symptoms they may be experiencing. We'll also look at some genetic testing and cascade testing as part of that whole person survivorship care. And thinking about this from a shared care model, looking at some of the experts we have tonight, you'll see how we work together in managing our patients' care. So to start with, when we think about how we define survivorship care, it's really complex. And if we look to the NCCN for guidelines, we have some sort of pathways or best practices, and it's pretty comprehensive. Everything from, once again, sort of reviewing where the patient is in their disease process and their treatment phase, thinking about what medications they're on, adherence to the therapies that we recommended, and the multimodality therapies that most of our patients have experienced. And then those common issues that we may see, both physical and psychosocial. So when we think about this kind of comprehensive list, I'd like to know from our panelists, how do you dive into this? Because this could be a pretty long visit. Is this something you tend to break up? Do you sort of have a cadence that you use? Or how do you address sort of this list or this to-do list when you're thinking about your cancer survivors?
Well, I can tell you that in our survivorship clinic, we prepare a care plan for them ahead of time, ahead of that visit. And that's probably what takes the longest, because we have to look at everything that patient has had, including side effects that they had during the treatment, what kind of treatments, radiation, what kind of surgery, reconstruction. And so that part is but it helps because once you do the visit, now you have a guidance. And it also, during that visit, you can identify what are the patient's needs and what referrals have not been done up to that point that you need to initiate. And you discuss them with her. Yeah.
And Dr. Mirabeau, would you also say, from a radiation oncology standpoint, you're kind of seeing what your surgical partners or your medical oncology partners have done. Do you add to it? Do you take over some of those responsibilities? Or how do you sort of role delineate between your partners?
So it's a hybrid. Usually we'll see a lot of our breast cancer patients in a multidisciplinary setting pre-surgery. So it's a very collaborative discussion where the patient gets to kind of hear the different options for surgery and how radiation plays into that. That's especially relevant for patients getting like a mastectomy with reconstruction. And in terms of some of the longer term survivorship issues, I think the discussion of radiation side effects kind of lends itself to that, because we tend to think of our side effects in terms of the short term, so kind of during the treatment course, versus some of the more longer term lingering effects 6 months to years out. So generally, even at the upfront consent process, I at least allude to some of the longer term survivorship issues. And so that usually comes up in those discussions.
So you kind of tee up those expectations, which is, I think, one of the biggest sort of missed opportunities for some patients is they feel like they don't or haven't heard maybe some of that expectation management. So having that discussion is really important. And Dr. Rojas, we're going to get more into some of the expertise that you have, especially in dealing with sexual health. But what would you add to that in regards to this discussion?
Yeah, I think that I oftentimes in the preoperative visit try to counsel patients on, the fact that mastectomy comes with a lot of side effects. Sometimes they can be long lasting, like issues with pain, what the effects of reconstruction may be. And so that aspect of survivorship does factor into my preoperative visit. Post-operatively, I try to kind of prepare them for the next steps. I also work in a large group with a fantastic team of multidisciplinary members and providers, and I try to set them up for what the next step is. I think managing their expectations can help minimize anxiety and at least get the thought in their mind about what's coming next. In the Music, Sex After Cancer program, I'm fortunate to work with an amazing team that brings the sexual health issues up and appropriately refers them to the program. So it really does take a multidisciplinary shared care model.
Oh, absolutely. And I think that as we kind of dive deeper into the most recent NCCN updated survivorship guidelines, when I look at this list and I think about sort of our process, which it's very similar to what Mayra described, where our advanced practice providers or nurse practitioners and PAs, they tend to do a lot of this more comprehensive sort of review with our patients. But this sort of assessment, takes an experienced provider. I look at some of the late effects that our patients experience and really dealing with whether it's hormonal management or thinking about some of those cardiotoxic issues. It takes a lot of sort of boots on the ground. It takes professional development, but this would also take like 6 hours if we did like official sort of batteries. So when you're looking at this, are you going to use maybe some patient reported outcomes, or do you actually kind of have a differential that you use, Mayra, when you're meeting with a survivor?
Well, I use several tools, and I usually try to refer them. For example, a lot of them have misconceptions about alternative or complementary medications, and I try to bring that back to the evidence base that we have, and that's the most important part. Everything else, we have studies on, and we have support throughout our institution that we can refer to. But some of the things that they hear outside, and some of the I have one lady, for example, that went to a store, and they sold her a curative type of powder, that cost her $180. And I have a site that is by about herbs by Memorial Sloan Kettering, which is wonderful. I love it.
It's a great resource.
Yes, great resource. I looked into it, and immediately the one thing that it said is, if you have hormone positive, you do not take this. So when I showed it to her, she said, "Oh my God." And so at least with that person, I had an impact. I can go to bed and feel good about what I do in life, So
sure. So you really have an inventory.
And like you said, it does take time to inquire about these things, which they don't naturally tell you. Oh, I got this powder. They don't. You have to inquire about them. So the whole thing takes a lot of time. You're absolutely right about that.
And what I'm also hearing is that, you know, and this is something I always encourage folks to do, is to do an inventory of what you do have within your practice, within your health system or organization or community or online, so that as you're identifying opportunities for patients, it doesn't have to be something that we have, you know, right across the hall. Obviously, that's the most convenient, but a lot of community practices or a lot of us, maybe we don't have that resource. So I think one important thing that I think is essential for providing whole patient care is to develop sort of your actual and virtual resources so that you do have kind of evidence-based and things you feel a little more secure with in providing your patients. And anything that the others would like to add to kind of our discussion about sort of this list of comprehensive review of our cancer survivors. It does take a village, though, that is for sure. So I think we're going to kick off with case study 1. And this case, I'll let Dr. Rojas start. Were you going to? No, I'm introducing this case. Sorry about that. And this is Teresa. This is a real patient who's been de-identified. So you guys don't have to worry. We won't let you know any real secrets about her. But she's a 56-year-old postmenopausal female. She was diagnosed a little over 5 years ago. She was triple positive, and she had a lumpectomy with actually no dissection, followed by radiation. She had pretty standard of care treatment for the time, receiving adjuvant AC, followed by Taxol, followed by a year of Herceptin. She underwent just a single syndrome testing for BRCA1 and 2 and was negative. She does have, oops, sorry about that, a positive family history of cancer. And being that her aunt had breast cancer in her 60s, her father had colon cancer in his late 50s. And she's been on an aromatase inhibitor for about 5 years. So since her treatment, she has unfortunately gained weight, which is not uncommon. We know that in particular, a lot of our premenopausal patients, they will gain anywhere between 15 to 20 pounds because a lot of them do go through menopause, such as Teresa. She's developed arthralgia from her aromatase inhibitors, hot flashes, mood swings, and she has some sexual side effects. She has some persistent radiation skin changes. She ended up having some update testing when she saw the Survivorship clinic, and she was found to have a CHEK2 mutation. So she has 2 daughters that are 18 and 22. And unfortunately, she went through a separation and now is divorced from her partner of 25 years. So this may sound like, oh, really, did all this happen to one patient? But all this does happen to one patient. And it's not that uncommon that our patients do have sort of complex, not only health histories, but personal histories that sort of go along beside that. So as we think about Teresa and we sort of put her into perspective, you know, what would be your first sort of mode of conversation when you would see this person, Dr. Rojas? How would you start when you would see her back, or maybe she's referred to you because of her sexual side effects?
Yeah, so one of the main goals of, you know, even if I was just seeing this patient for adjuvant follow-up outside of the music program, you know, I would want to know, try to figure out what symptoms bothering her the most, because you know, hot flashes, before I got into cancer care, I didn't realize how incredibly terrible they are, especially if they're waking patients up at night. Their day, the following day is completely disrupted and can contribute to anxiety and mood issues. And so that is a pretty easy one to target. And I try to almost lead with that and see how bothersome those are for the patient. As far as the sexual health after cancer program, when patients are referred, you know, I kind of start with, this is a program that we've developed for women who are experiencing sexual side effects after treatment. It's very, very common. Common symptoms include vaginal dryness, painful sex, and low desire. Are any of those symptoms something that you're feeling? Or maybe you can tell me more about what you're feeling. And then I just listen. I find that, you know, making time, having the program specifically for that, where I have time to just listen and let the patient talk, I end up learning a lot about their problem, learning a lot about the problems that patients face in general, but also I feel like the patients feel a lot better finally getting some of that off their chest.
Mm-hmm. But you've also sort of highlighted something that I think, especially when talking about things that are sometimes uncomfortable for patients, like sexual health, sometimes money, which we'll talk a little bit about, financial toxicity, and sometimes even sort of psychosocial issues. When patients have when they feel that that may be something abnormal or they're uncomfortable talking about it, you kind of tee it off by normalizing that, like patients do experience this. So do you find that that's a good tactic to get them to sort of open up by kind of normalizing that these are common side effects that patients experience?
Yeah, I think it's important to exactly normalize the conversation, talk about it normally, say what you mean and tell the patients this is so common. 80% of breast cancer survivors, specifically women on aromatase inhibitors, are experiencing these issues. We haven't done a great job addressing them until now. And so this program is just for that. And then they'll know, oh, this is actually really common, even though I haven't spoken to my friends about it. And also, wow, if they have a program just for this, like everyone must be feeling
It must be.
Mm-hmm.
Absolutely. And
I want to add just about,
yes, please, Dr. Mirabeau, go ahead.
Oh, no, sorry. But, I think that a lot of times, especially now from a radiation perspective, for example, that for early breast cancers in ladies over 65, the option of taking an aromatase inhibitor alone is kind of driven by more level, 1 evidence. But the side effects. So a lot of times having patients who just find, an aromatase inhibitor intolerable because of the hot flashes or arthralgias, then usually I end up seeing them back later, a couple months after they've tried a few different options, and we're doing a short course of radiation. So in our clinic with our partners, we try to kind of be very transparent about kind of some of the different side effects, our thresholds in terms of kind of tolerance, when to switch agents. And then also we just do a lot of short course radiation in some of these women as well. And we'll talk later about some of the skin side effects from a radiation perspective, just because sometimes the idea of having side effects for 5 years versus a shorter course of skincare side effects, for different patients, you want them to be able to make an informed decision for what fits their needs.
Yeah, you're helping them do that cost benefit. I think that that's really so important because we talk so much about shared care and about sort of that shared decision making, but the reality is sometimes it's sort of embedded in that conversation you just described, but it's very important for it to happen because a lot of patients don't know they have those options, or they don't really understand that there are choices. And in breast cancer in particular, where we do have a lot more therapeutic options than some other diseases, there really are choices that they have to make. And Mayra, did you want to add anything to that based on kind of your experience with survivors as well?
Yes, for better or for worse, I am a breast cancer survivor myself. So I think that in the 15 years that I've worked in oncology in breast only, because that's when I decided to switch, that's the most important thing I can contribute. So all my knowledge, all my schooling, all my training doesn't contribute as much as being able to let them know, hey, you're normal. I've been there, done that. You are normal. This is not anything outside. And we have this, and this in place to help you. And
Great.
I mean, that's my particular feeling in everything that I do in breast oncology. That's the most important thing.
And I think you bring up, the personalization that you're able to bring to your practice is unique. And I think that whether it's experience, whether it's just listening to our patients, or whether you're sharing your lived experience, the key that I've heard from all of you is really normalization, listening, and being able to help the patient prioritize what's most important to them. So we're going to dive more into each of these issues and really talk through that. And we're going to start with kind of thinking about the snapshot of Teresa. So when we think about that whole person, based on the treatment she was given, she had several cardiotoxic therapies. She had adriamycin, she had Herceptin. She's gone through menopause and she's still living through that with her aromatase inhibitor. She's gained weight. She probably is going to report a little fatigue. She has risk of a second cancer now that she has that CHEK2 mutation. She's always going to worry about risk of recurrence. That's something that never goes away. What should we be educating her on? Lymphedema? What about her bones? What about, her cognitive function? Is she able to maintain her employment? So this is sort of the thought process that we should be kind of thinking about. Now, we don't want to give a patient this laundry list and say, hey, do you have all of these things? Because sometimes people do have all of these things, or sometimes they tend to convert to having more of these things. So we want to be very, They should have a list, but I don't always like to tee it up by suggesting that they should have every issue that we give them on a list, if that makes sense. Because sometimes that can is not always the most effective. You also want to be able to ask the patient questions so that they can tell you what are their biggest issues or their biggest concerns. But this is something that we should be thinking about and we should be sharing with our patients. So let's talk about that effect of estrogen. And Dr. Rojas, do you want to kind of kick us off in talking about kind of the pros and cons of estrogen and estrogen deprivation?
Sure. Well, first and foremost, estrogen has gotten a really bad rap. And starting with the Women's Health Initiative that was picked up by the media, saying that estrogen and estrogen plus progestins increase the risk of breast cancer. You know, long-term data has shown that estrogen alone does not increase the risk of breast cancer, and estrogen, you know, these bigger, more higher dose androgenic progestins may be bad actors. But, you know, everyone still remembers, oh, estrogen and breast cancer. Now, so it's hard to convince patients that estrogen isn't necessarily, well, a bad thing when we're blocking estrogen to keep their cancer from coming back. But I don't think it's quite that simple. I think it is more complicated than just blocking the estrogen. You know, I think, and then one of the important aspects to highlight to patients is that a lot of their symptoms are due to the low levels of estrogen. And I explained to them, you know, normal menopause happens little by little. Estrogen goes down little by little. Your body kind of gets used to the lack of estrogen, which, you know, affects your bones and your brain and your heart. And it's more of a gradual process. When we put you into menopause, either with chemotherapy or start you on ovarian suppression, or just make the menopause that you already had kind of a super menopause that is honestly like nothing's very super about it, the level of estrogen in your body is even lower. It's so low that we can't even measure it with really sensitive assays. And so I start by explaining that and almost kind of like congratulating them on putting in the work and doing all of this, and then reassure them that there are some things that we can do to alleviate some of the symptoms without necessarily giving them estrogen back. So it definitely contributes to their overall quality of life. We do know that long-term estrogen deprivation can potentially increase all-cause mortality, and that's why we definitely try not to do early oophorectomy in patients who don't have a BRCA mutation, you know, because oophorectomy really does make their estrogen lower than if they're on Lupron. And I think some of the issues with potentially like bone protection and dementia risk and long-term cardiac morbidity really is, those risks are heightened when we do these early oophorectomies in patients where they may not be indicated. So.
Yeah, and I think there was a nice study out of Mayo highlighting that and showing that those women, I think in their 30s and 40s, who had that early, you know, surgical intervention, they actually had that kind of rapid onset for both cardiovascular disease and for dementia at about a decade early. So I think that acceleration really is something to be concerned about, and something that some of our patients, especially if that's in their personal or family history already, definitely needs to be brought into that discussion.
Yeah,
so
a lot of what I do is talking to BRCA mutation carriers who've had an oophorectomy and convincing them that a little bit of low dose estrogen, if they've had a hysterectomy, is okay.
Yes, that is a kind of a mixed bag when you have to spend a lot of time with that discussion too.
Definitely. So, you know, as all of our listeners probably know, endocrine or anti-estrogen therapy is paramount and decreases the risk of recurrence significantly. And so we know that patients who stop their endocrine therapy early or patients who are not compliant have worse outcomes. And so the biggest side effects from that are menopausal symptoms, you know, and like as a society, we don't do a great job preparing women for normal menopause. So when we have women that are all of a sudden put into a menopause they weren't prepared for, it's tough. Like they have a hard time bringing up those concerns, and like as an industry, we haven't really done a great, or the industry hasn't really responded with a whole wealth of options for them. And I think that's why one of the reasons a lot of patients turn to these alternative therapies. it's important to know that patients who don't get anti-estrogen therapy will also experience these symptoms. So women who are given chemotherapy in their 30s and 40s will go into premature ovarian failure, and it'll feel as if they're taking tamoxifen or an AI, even though they may have triple negative breast cancer. And so it's important we don't discount those patients who are experiencing the same symptoms, especially because sometimes we have a little bit more wiggle room with regards to how we can treat their symptoms. So as you said before, we talk about setting expectations, and what I wanted to do is kind of empower our listeners to have their own algorithm for addressing these issues when they come up, so that it's not so intimidating, and you have your go-to steps, and it doesn't have to be necessarily, an hour long where you're running late in clinic and trying to get out of the room. So. First thing is with hot flashes, because this is an easy lifestyle fix. So I talked to them about behavioral interventions. Like I said before, they disrupt sleep. And sometimes patients report that when they get an onset of a hot flash, it's like they're having a heart attack or having an anxiety attack. And it can be really distressing for them. So exercising in the morning, like good high intensity interval training in the morning, actually helps with hot flashes later on in the day. Dressing in layers and avoiding trigger foods, like all of the delicious things that we love, like spicy food, caffeine, wine, basically everything great.
All good things.
Yeah, exactly. I want to talk about the two, probably in my experience and according to the literature, most effective ways to treat hot flashes that are non-hormonal. One is venlafaxine. The standard SNRI dose is 65 milligrams, but you can get, depending on their insurance, a half dose of that. And patients are always like, ooh, antidepressants, I don't want to take one of those. But I reassure them, I'm going to start on this baby dose, because hot flashes actually really are coming from your brain. It's your brain's thermometer thinking that you're cold when you're actually not. And then they're like, oh, okay, that makes sense. And so I talked to them and kind of try to take the stigma away from a low dose antidepressant, because venlafaxine is very effective. And then a newer tool that we have in our armamentarium is oxybutynin. There's a study that came out recently showing that it's effective, and you can start at 5 milligrams every day and titrate up. So I'll sometimes start at 5 milligrams, talk to them about some of the anticholinergic symptoms and tell them to call me if they experience them. And then in 2 weeks, if they're still having hot flashes, I'll titrate them up to BID. Caution, remember from medical school, narrow angle glaucoma, you don't want to give them anticholinergics. But I'm not a urogynecologist, but I feel comfortable starting patients on low dose oxybutynin as long as I document that I counseled them. And then gabapentin is very sedating, and it's only effective at 900 milligrams a day. And this was not my patient, but I've known a patient who was started on a large dose of gabapentin and was in a car accident, because patients can be really, really affected by this. And being sedated all day long when they're trying to get back to their normal lives is not helpful. So I kind of stay away from gabapentin. To me, gabapentin has much more of a medical legal risk than venlafaxine or oxybutynin. I talked to them about acupuncture because there is emerging data that acupuncture is really helpful for hot flashes. And then there's a newer product on the market from a company that I like called Bonafide that has a lot of other non-hormonal menopausal products. And it's a supplement called Ristella. And its active ingredient is this type of bark. And they've been using it in Europe to treat menopausal symptoms. Sorry, I can't remember if it's Relizin or Ristella, but it's on the website. But anyways, there's this non-hormonal supplement, and there is data showing that it helps with hot flashes. And then I talk about potential psychosocial interventions if anxiety is an issue, and then nutrition referral if once we start to talk about exercise, and that also goes into like weight management. So I always bring that up.
And so your bag of tricks has you have a lot of tricks, which is good, because I think that one thing that you brought up, which is important, that if you're having your sleep disrupted, if you're having hot flashes and you're not able to concentrate, that's going to affect your mood, your sleep disturbance, your ability to concentrate. So that one sort of stimulus is going to have all these negative reactions. So you kind of have to start with one and tackle one versus, trying to start with this constellation. But it seems like managing the hot flashes is going to have a positive effect on lots of other potential side effects for the patient.
Yeah, I'd say it's high impact on improving their quality of life.
And for anyone who's had hot flashes, it definitely does make a difference to your quality of life to control them. Mayra, did you want to add anything to that based on, the patients that you're seeing?
No, I think that's right. One of the things I also recommend is something, really like bamboo sheets and bamboo sleepwear, because that keeps them dry. And mainly reassurance, because usually the hot flashes, especially due to treatment, do not last years. Eventually they go down, and that's mainly what I tell them. Listen, be patient, use these things, don't think you're going to be using them forever, because they're afraid like
Sure.
Dr. Rojas said, they don't want to use venlafaxine because it affects. I just talked to someone about that today. It affects their head, and I said, no, this is important. It does, your brain is the one telling your body to do this. So please, take it. You're not going to get used to them, and this is temporary. That's the main thing, is just reassurance, because it is very annoying. And like you said, anybody who's had them knows
Oh,
how
absolutely.
painful it is.
And that there are some strategies. And so I never want patients to feel like they don't have options. And you've just given a nice list of those. And then kind of moving on to the next phase of their management. We'll let you dive into this as well.
Yeah, so along the same vein, I think reassuring patients that, okay, this is what we're going to try first, but if this doesn't work, I have something else, so don't give up. Like, don't give up on me. Come back and we'll try something else. Like, I have more options for you. And that goes with the hot flashes, but also with managing the sexual side effects from treatment. And so almost all my sexual health after cancer program patients come in and it's either dryness or painful sex. And, vaginal atrophy is now the term we don't use anymore. It's now called genitourinary syndrome of menopause, which is not a very sexy term either, or GSM. But so I go through kind of like I do this in a stepwise approach. And I even have this kind of printed out and give it to patients. So the first thing I talk to them, because oftentimes if you can treat these symptoms, if you can fix this aspect, you can fix the painful sex part. And then maybe even that downstream helps with libido when they're not associating sex with pain. So first thing is eliminating irritants. This is a part where I go into a little bit of education, because like patients think that they need to be using soap in the vagina. And I always tell them like, nope, the vagina is like a self-cleaning oven. All it needs is water. And like, I go through this whole thing where there's good bacteria and bad bacteria and these like feminine washes, which is like the new word for douche. There's like an entire aisle in the grocery store for these, and I want to like go and just like knock the whole aisle over, because like the vagina does not need to smell like peach blossoms. But that's my like PSA. So I talk to patients about that. I talk to them a little bit, and that also includes like detergents you wash your underwear with, like use the free and clear one, panty liners that have fragrances in them, even toilet paper, things like that. And then I talk to them about daily moisturization. So moisturization is separate from lubrication. Moisturization is maintenance. So just like you use your under eye cream at night, now you're going to moisturize the vulva and the vagina. And the first step for that is everyone has coconut oil at their home, in their home. So I have them check the labels, make sure it's single ingredient, organic coconut oil, solid at room temperature. When you rub it on your fingers, it becomes an oil on the outside of the vulva after showering before going to bed. Some of the product works its way up, does not increase the risk of yeast infections or that, but it does also protect that really delicate skin from acidic urine. Kind of a higher tech molecule that a higher tech product that has hyaluronic acid is my next go-to. And sometimes I'll start with that if their symptoms are kind of severe. There are Hyalogyne and these like suppositories that are hyaluronic acid. These are like the new kids on the block, and they're really, really effective. And so look into products with hyaluronic acid or lactic acid, because lactic acid helps balance the pH and promote the development of lactobacilli, or bringing back lactobacilli, which helps vaginal and vulvar health. So I actually never recommend Replens, and patients always get to me and they're like, oh yeah, I tried Replens. Like, Replens isn't that great of a product. It has like a lot of other stuff in it that can irritate the skin, and it leaves a weird film, and there's like way better things we can offer them now. If hyaluronic acid isn't working, then I talk to them about vaginal androgens. And so there's studies showing that progesterone, which is a DHEA, does not increase the circulating serum estradiol. It's FDA approved for painful sex, and there's androgen receptors in all of the areas of pain that these patients have around the introitus or the vagina. And so it really does help with pain, and some of it, I believe, is peripherally aromatized without increasing serum estrogen. So if they have insurance, I recommend progesterone. Another option is compounded low-dose vaginal testosterone, but I'm really, really picky about compounded stuff, and I like to grill the compounding people before I ever send a script for that. So that's a little bit, not FDA approved. Vaginal estrogen is not necessarily contraindicated in these patients, but I'll talk to the medical oncologist. If they're really uncomfortable with vaginal estrogen, I'll say, okay, what if we put the patient on tamoxifen for a while, gave her vaginal estrogen then, at least for a couple months, use dilators, we can increase elasticity, recolonize the bacteria with lactobacilli, and get the patient back to where she can have sex without pain. Because a lot of times once they have pain, they stop having sex, and then the architecture of the vagina changes. It becomes shorter, narrower, and it's hard to get back to where they were before without vaginal estrogen. Vaginal estrogen is also helpful for recurrent UTIs, but if you have a patient that's having this, especially if they're having postcoital UTIs, you can give them single dose macrobid or single dose nitrofurantoin, 1 pill after sex, and it helps prevent those postcoital UTIs, which is like also another little easy fix. Whatever you use for moisturization, if they're young, you want to make sure it's compatible with condoms and counsel them. If they're using coconut oil, any oil can degrade the latex, so it's important to tell them that. And then I talked to them about lubricants. So the same concept about eliminating irritants, avoiding fragrances, tastes, warming, all the gimmicks, like don't use it, not for you. And avoiding long name chemicals, glycerin, petroleum-based products. These are some of the brands that I like. And I didn't tell you that we didn't talk about disclosures, but just FYI, I have no financial disclosures related to any of these products. These are just things that I've tried and that patients have told me about and I've gotten feedback on. And so painful sex usually goes along with GSM. What happens is they feel pain. They have this feeling in their anxiety in their brain about associating pain with sex or sex with pain. And then they start to have levator spasm. And that's something that pelvic floor physical therapy can be really helpful with. So find a pelvic floor PT person. They're amazing. Their first time visits are super comprehensive. They go through like what the patient's eating, how much water they're drinking, obstetric injuries, all of these things that contribute to pelvic pain. The O-Nut is this amazing device that is basically like a bumper you can put on the penis. It's like a ring, a jelly ring, and it helps decrease deep penetration. So for patients who are having pain with deep penetration because of pelvic floor muscle dysfunction, I direct them to the O-Nut, which is a cool product. Urogynecology is also a helpful referral. I don't prescribe topical lidocaine, especially as a first choice, because I don't want patients to have lidocaine, be numb, have sex, and then have a lot more pain afterwards. I feel like that just kind of makes it worse. And then for patients on aromatase inhibitors, I actually do not recommend any of the laser products. Those were not FDA approved to be used on the vagina. The responses are variable in women with a history of aromatase inhibitors because the estrogen is so incredibly low that mucosa can't heal correctly. And so the use of these lasers really does depend on that mucosa being able to heal. So probably okay if you can use it with vaginal estrogen or patients on tamoxifen, but I don't recommend it for patients on AIs until there's better long-term safety data.
That was really comprehensive and helpful. I think the important part is there are, once again, a lot of tools that we need to have in our toolbox. I think as you kind of alluded to, though, there's multiple phases to addressing this issue. And I think libido also obviously gets impacted by a lot of different things of the breast cancer diagnosis and treatment.
Yeah, and libido is the hardest thing to treat. Like if a patient doesn't have GSM and she's just like, and I just have low desire. And that's really like the hardest thing for me because it's so complicated. But some of the things that I kind of go stepwise, just like with GSM. And I think about trading, assessing their meds first. So SSRIs can have really intense sexual side effects and can actually cause complete anorgasmia. And so bupropion or Wellbutrin doesn't have sexual side effects. So I asked the patients who are on SSRIs to talk to their psychiatrist to see if that would be an appropriate medication for them. Beta blockers can zap the libido, and then patients on AIs who maybe could go on tamoxifen at least to see if it helps may experience some symptom relief. I go back to exercise just like everything else. If you feel good about your body, you feel more sexy. And then I talk to women about how, I always tell patients women are like crock pots and men are like microwaves. And so, even if you maybe when you were in your 20s could just like turn it on or, and I always say like sex is not like Hollywood either. Like it takes preparation. You're going to have to plan it. You may say on the date in this calendar, this is when we're going to have sex, and you want to think about foreplay and you want to think about all the things you need like for your atmosphere. And then the other thing is sexy podcasts. So like I have sent patients to Dipsy Stories or Quinn, which are these podcasts led by women. And then I talk to them about their partner. I talk to them about this non-hormonal supplement from that same company. And then the two pharmacologic options, one is flibanserin or Addy, which is a serotonin modulator. They had a black box warning due to an interaction with alcohol, which was removed. If they drink a glass of wine or two, no big deal. But if they're drinking a lot that day, don't take their medication. Maybe effective, maybe not. It's worked for some patients, but not all of them. But I have to counsel them about the potential side effect of dizziness. If they feel dizzy, to skip to every other day. The new kid on the block is this bremelanotide or Vyleesi injection, which is an injection you give yourself before sexual activity. But I haven't gotten any cancer patients to agree to that because they don't want any more injections. And so I'm still waiting to kind of see how that pans out. But just so everyone knows, it's compared to the 5 Viagra products that are on the market, women have 2 FDA-approved treatments. So progress.
Yes, we've always tried to think about the woman's version of Viagra. So it's good to know that folks are actually out there researching that. All right. So I think that as you kind of look at those options, one of the reasons that's also important is because we have adherence issues. And if we don't address some of those negative side effects, we know, as we heard earlier, that, if we can't keep patients on their therapy and that's what's effective for cure, then we're missing that opportunity to help patients be adherent to their therapy. So this is not just an important factor because it's important to the patient, which should be one of our priorities, but it's also an important priority to keep patients adherent with their recommended 5 to 10 years worth of anti-hormone therapy. So as we highlighted, those most common side effects are hot flashes, but our patients also experience some musculoskeletal symptoms and fatigue. And I think these are pretty common and also common reasons why patients may discontinue or be less compliant with their AIs and recommended therapy. I think there are obviously some strategies for that. And so Dr. Rojas, when you're talking to patients about that sexual health profile, are you also incorporating in some of the benefits in regards to these other kind of AI related side effects?
Yeah, definitely. Duloxetine can help with those musculoskeletal symptoms, but like I said, can zap your libido. So it's kind of like a balance about what's really bothering the patient the most. But I'm always going back to the exercise thing and reassuring patients that actually exercise will help with this, and it will help with a lot of these issues, and also will help with fatigue. Even though you may not feel like exercising, you'll feel better afterwards.
Absolutely. And I think one of the most common things that we see is patients who have unmanaged thyroid dysfunction. And especially, I'd like to hear from Dr. Mirabeau as well as Mayra, when we're thinking about radiation or we're thinking about, our longer term survivors, how do you guys help in identification and management, or is that something you would encourage back to a primary care to address?
Definitely after our patients finish treatment, I follow them weekly until their symptoms resolve. So I like to be part of that kind of subacute management piece. Fatigue is so poorly understood mechanistically. I think for our patients who have more complex cancer paradigms where they're getting concurrent chemo, radiation, that makes sense. But for patients who are otherwise active, healthy, and are just getting very focal radiation to the breast, I'm always surprised still when some feel pretty significant fatigue. And I think, the data would suggest it's pretty multifactorial. There's probably an emotional component. It is inconvenient. They're coming back and forth for daily treatments. And there's probably some component of kind of inflammation that's going on that's contributing to it. But I think kind of in the same spirit of a lot of these side effects we're talking about, kind of normalizing the discussion, giving patients permission to kind of go easier on themselves since their body is going through a treatment, and then having that discussion. So I make myself available, kind of throughout the patient's treatment and, in the months and first years after, to kind of go through these side effects, because a lot of women bounce back sooner or later than others. And it's just important for them to feel that they have a doctor that's like listening to these complaints.
Mm-hmm.
And for my part, at some point, we're going to be talking about, financial toxicity. So, a lot of times, and, I've had discussions and things with the, with the oncologists that I work with, because it's very easy to refer the patient back to the primary, but who can afford all those co-pays? Because remember, we're seeing them at least 6 months regularly, then every 3 months. That's a lot of co-pays. Even a working person has an issue. So even at that, so the financial toxicity starts at the very basic part of care. So I do counsel them, and I do try to keep it within the people, like if it is a radiation induced fatigue, keep it with that. And just to add to what Dr. Rojas said, one of the first things I do is when I do my teaching before they start, I said, the antidote to fatigue is exercise. That, or I asked them, do you know what is the antidote, just so that that little piece is remembered sometime down the road, because that's such a thing. Antidote, oh gosh, I want that, So
it's also something the patient can do. Yeah, for sure. Yeah, it's sort of giving the patient some, patients are following our directions, but we don't always give them, well, here's your recipe. And I think exercise is one of those things we should be prescribing to every patient that we see, even if it's limited exercise based on their functionality. So we also know that, as we think about some of these experiences, whether it be adherence, whether we'll talk about cardiotoxicity a little bit, we know that kind of the extremes of that spectrum, our youngest patients or oldest patients tend to be those at highest risk for some of the adherence issues, as well as for some of the late effects. So I think if you're going to kind of hyper focus on areas of highest risk, our youngest and oldest patients obviously are those sort of low-hanging fruit and categories to focus on. We included a couple slides from just the Mayo Clinic experience, and Dr. Leon Ferrer gave me permission to include these just because I think it's nice to see, under Dr. Loprenzi's guidance, they've done a lot of different studies looking at a lot of different agents to help manage side effects, including hot flashes and other menopausal symptoms. And it's sort of across the board, but you're seeing very similarly what Dr. Rojas highlighted as what are some of the most effective interventions, as well as some of the limited success that there's been with some of the more natural products, things that had promise, but really haven't panned out. So I think it's important that we look to the literature, we think about what has been evaluated, and I think there's some good guidance, and you also had some good guidance from Dr. Rojas in looking at that. This was just published, and this is from the Oncology Nursing Forum, and this was a meta-analysis that looked at kind of all the trials that have been done, how do they kind of pan out? And so I think that this is also a good reference. If you haven't seen this, it is something nice to look at because it gives you not only the hot flash frequency, but also the intensity. And so you're seeing very similar sort of reductions based on some of these therapeutic interventions that have already been covered. So I just wanted you guys to have those as a reference, because sometimes it's nice, and we know that our breast cancer survivors tend to be some of the most informed consumer medical patients out there. So I think it's nice to have that data for them and to support some of those recommendations that we would give to our patients. And that feeds also into bone health. And once again, we talked about the importance of really looking at sort of those risk factors, AIs and age being one of those in menopause. And then Mayra, from your perspective, as you're seeing these survivors, are you going to be ordering the bone densities? Is that something done or triaged back to primary care? Or how do you kind of co-manage that in patients based on NCCN guidelines and managing your patients?
Well, the majority of the time we do. And I think it's because we need to take ownership of what we may be causing. Okay. So, and we usually do that the majority of the time. I mean, once in a while, there could be a outlier that did not, but the majority of the time we do that as a baseline. So we know right away. And one of the good things about that is that we, if the a lot of times get surprised that the patient already has osteopenia. So we have, a cushion, and we can say to the patient, look, the pill did not cause this. You had it at baseline, and we then act proactively. So that in fact reduces, and the reduction in bone mineral mass, so or density. So we do take ownership, and I'm very happy about that. Calcium and vitamin D, we recommend, or at least, I have a form that I do my chemo teaching, and I recommend that from the get-go for all patients, not just for patients that are hormone positive, that, are going to get anti-hormonal therapy at the end. No, I do it from the get-go so that I get them used to it.
And I think the NCCN guidelines would support that. And it is something where sometimes we do see primary care ordering bone densities because that's part of their well person care. But I think ultimately there needs to be that role delineation that if primary care orders it, we still need it as part of the cancer care team because we're going to be the ones most likely ordering, any anti-osteoporotic medications and so forth, as these are not always, in the bag of tricks that our primary care providers would feel comfortable ordering in a patient with a history of cancer. So that's really where that shared care kind of comes in. So I think as we think about, our summary, kind of thinking about menopause management, we need that education and assessment. We need to think about our patients at highest risk and what their priorities are. And we really need to have ability to have a conversation or have one of our team members or resource or referral where these issues can be addressed because they do impact a majority of our cancer survivors. They are some of the biggest priorities that our patients have. And it's definitely something that once that's addressed has a significant impact in their overall quality of life. I think another issue that really does is a major side effect of menopause as well as cancer treatment is cardiotoxicity. So Dr. Mirabeau, I'd like to turn that over to you to do a little discussion on cardiotoxicity.
Sure. I think this is a great slide that kind of shows the magnitude of effect on our society in numbers. So if we look at heart disease, there's over 47 million women living with some form of cardiovascular disease, and greater than 289,000 women will die each year from heart disease, which is actually 5 times more than breast cancer. And it's really the leading cause of death. So 1 in 4 women will die from some form of heart disease. Breast cancer, obviously very passionate about it in this crowd, among others. But, there are 3.3 million women living with some form of breast cancer, and 41,000 will die each year from breast cancer. So especially as we have better outcomes in terms of our treatments, the long-term effects as well as kind of the coexisting comorbidity of cardiovascular disease with our breast cancer patients becomes very important. And we're seeing more early stage breast cancer patients over 65 who are now dealing not just with the survivorship issues of their breast cancer, but also concurrent heart disease risk factors and risk features. So, when we're thinking about cancer treatment, it's really kind of a multiple hit process. So obviously patients kind of enter their treatment journey and diagnosis with baseline risk factors. And that can include things like, their weight, hypertension, their age, their present fitness level. Then, our treatments themselves are a physiologic hit. Granted, it's to cure them of their cancers, but we're always factoring in kind of interactions between their existing medical problems as well as side effects from our treatment. And then you then have the secondary effects kind of after the after effects of treatments of deconditioning and weight gain, and some of those we've already touched on. So looking a little deeper in cardiovascular implications, this is just a slide that looks at some of, oh, no worries, that was perfect. Looking at some of the long-term cardiovascular consequences in breast cancer survivors. And basically we see that the risk pretty much stays steady and even slightly increases for cardiovascular disease from diagnosis kind of going forward. We don't see a plateau. Breast cancer, years out from diagnosis in terms of percent mortality, obviously mortality goes down because the further out from your treatment and diagnosis, generally, we're more likely to say that we cured you of your cancer. So again, the risk of cardiovascular disease becomes even more important. So from at least a radiation perspective, oh, this is another slide, I guess, similarly showing the juxtaposition of the mortality. But yeah, that's perfect. In the interest of time, we may as well jump to the fun radiation slide. So to really minimize cardiac toxicity, because there's been a whole generation of data that's looked at our ladies treated for left-sided breast cancers and showed that, especially with some of our older techniques where we weren't as mindful of scatter radiation dose to the heart, those ladies got earlier cardiovascular disease of a greater magnitude. So now even NCCN guidelines, and this is an older version, but it's made it into the newer iterations, emphasize that really different techniques to minimize cardiac dose, and I've highlighted a few of them that I'll walk through, are really an important thing that treatment physicians should factor into their radiation treatment planning. So in the upper right corner, I have an image from a patient being treated in the prone position. That's great because the breast is almost similar to the board used for a breast MRI. So the treated breast actually kind of flops through the table, and then we design our radiation beams to treat under the treatment couch. And that's great because, as you can see there, all the mediastinal structures are well protected and get almost no scatter radiation dose. A limitation of this procedure, though, is patients have to have good shoulder mobility, and it's also somewhat of an uncomfortable position to be in the swimmer's position for some of our heavier or older ladies. So, prone is a good option if you have a motivated candidate who can find it comfortable. Yet another option is what's in the lower left. So that's what's called a deep inspiration breath hold. So the first image on the far left is basically an example of a radiation planning scan, and the red contour represents our dose gradient. And there you see for a patient who's free breathing during their treatment, the field edge actually comes right up against the anterior contour of the heart, particularly near the left ventricle. Now, if we coach our patients to take a deep breath, and they have to be able to hold their breath for about 20 to 25 seconds, as the lungs fill, we actually push the heart further down in the chest, and you can see we can get a good few centimeters of separation from our deep edge of our radiation field to the heart. And there have been studies that have shown that we're able to decrease the mean heart dose significantly by using that technique. A limitation is the patient has to be able to hold their breath. So obviously older patients or some that have concurrent lung disease or smoking histories, that can be a bit challenging. Also some patients who are deconditioned from chemotherapy. But the breath hold technique is great, and there's a lot of different kind of onboard imaging platforms that we are able to do motion management during treatment. So we actually gate our radiation beam with a patient's chest wall excursion when they're in that perfect position. And then the two right-sided images are a contrast between photon radiation and protons. So there are a lot more proton centers kind of nationwide. We don't have it in Fort Myers, but they're at in Miami and Orlando and University of Florida. And protons, the far right lower image, just have a very steep dose fall off due to it being a heavy charged particle. So particularly for patients who don't have an intact breast, like your post-mastectomy patients, for example, who need comprehensive lymph node radiation, protons sometimes offer a dosimetric advantage where you're really able to carve the dose around the heart. And I have referred patients to get an academic opinion when I think protons will give them a benefit just due to their anatomy.
So I just tried to hold my breath for 20 seconds, and it is pretty hard. I know. So we have a couple things just dealing with lifestyle that we have as reference for you. But I think I'd like to keep going with your topic on radiation and sort of the late effects, but once again, reinforcing that lifestyle that we've talked about.
So a more acute effect of radiation are the skin changes. And I wanted to spend a little time on that just because I think sometimes the skin care that happens during radiation is a little bit of a black box to our patients and our colleagues. So this picture is kind of a typical example of somewhere between grade 1 to 2 skin toxicity. So grade 1, oh, sorry, previous slide again.
Sorry.
No worries. So grade 1 tends to be more faint erythema, superficial burning. The patient experiences that is tingling or itching. There can also be some hyperpigmentation depending on the patient's skin complexion. Grade 2 is when you start to see this kind of brisk, bright erythema. Sometimes you can get what's called dry desquamation, which is almost like a dry peel from a suntan. Grade 3 is more blistered sunburns. They can be confluent. There can be serous drainage. It's very uncomfortable and usually requires either pain control or prescription strength creams. We see our patients weekly during treatment to kind of get them through the skin reaction. And on the next slide, I have some of the kind of prevention techniques that I'll often counsel our patients on, just to have their skins primed kind of before they begin treatment, and kind of behaviors to avoid. But key things are basically, keeping the area clean and dry, lukewarm water, mild soaps, kind of similar principles to what Dr. Rojas was saying. Sometimes less is more in terms of products and fragrances and topicals. I tend to recommend just water-based moisturizers that are unscented, that can be used 2-3 times a day. Avoiding aluminum deodorant and antiperspirants, particularly kind of during treatments, helpful. And also avoiding things like cornstarch or baby powder in kind of the inframammary fold or the axillary fold. That's where really just the counseling on kind of skincare and hygiene can be really helpful, because, I think there's a whole line in the grocery store, like you said, Dr. Rojas, of products kind of, marketed towards these treatments that sometimes actually make things a little more complicated than necessary.
Do you find that, because you listed out baby powder, cornstarch, that maybe people feel like, well, if it was good for my infant, it probably would be good since I'm having, this potential late effect? And is that intuitively, are you having to kind of re-educate them and counsel them because it's sort of counterintuitive?
So it's a good point. It's not so much that they're bad for your skin as much as they don't prevent what the radiation is going to do. So I think some of it's more managing expectations. We kind of expect the skin to feel the effect of the radiation dose because it's killing hidden cancer cells in the breast. Kind of masking that effect and using too many topicals can sometimes, I think, more just be inconvenient and kind of drag out the process, as opposed to just kind of letting the body heal itself. So they're not bad as much as they aren't particularly useful.
That's a good point.
This was, I think, a transition into kind of lymphedema. It's a complicated slide, so I'll just add that essentially the less treatment, the less likely to have breast cancer-related lymphedema. The more escalated treatment, the more likely you will get it. So at the bottom of the image, you're seeing things like sentinel node biopsy alone, sentinel node biopsy with limited tangent radiation that's focused just on the breast, whereas we add axillary lymph node dissection, lymph node radiation, even different forms of cytotoxic chemo. Those combined modality therapies, really, you tend to see an increase in breast cancer-related lymphedema. And some of that's related to, I think, the disruption of the lymphatics from the surgery, and then also the scarring and fibrosis caused by radiation. I think the chemo question's a bit more confusing because it's likely that those patients had higher volume lymph node disease, and that's why they required more aggressive chemotherapy. And so they were probably more selection bias in terms of those patients having more breast cancer-related lymphedema. I think on the next image, I have another kind of getting into some of the risk factors for lymphedema. So, body mass index, I think exercise, stretching, yoga, all those things have been shown to be preventative and beneficial in terms of dealing with breast cancer-related lymphedema. And then the hazard ratios are, again, just showing the increased complexity of treatments and how intensified chemotherapy and nodal radiation and surgery increases your risk of lymphedema, which is pretty intuitive.
So I like the way you worded that. Kind of, it's pretty intuitive. The more therapy, the more risk there is. And so what would you recommend? Like with these patients, if you're going to give them, if they, in your multidisciplinary visit, you put together a more comprehensive treatment plan, should they have pre-treatment assessment, education with a lymphedema specialist, or what would you recommend in that regard?
Absolutely. I don't know if it's the next slide or a couple slides in the future, but essentially, there's a whole body of work looking at kind of prospectively measuring women's arms, so we have a sense of, what their baseline measurements are, and we do that for all patients seen in our clinic. And there's different measurements, but we use a SOZO kind of infrared camera to kind of measure arm circumference. And then I think definitely referral to a dedicated lymphedema specialist is preferable. I think also just managing expectations, like we've talked about again and again. Our first step is to really beat the cancer. So, obviously, if a patient has high volume lymph node disease and requires a dissection and comprehensive lymph node radiation, I wouldn't say they shouldn't get that treatment to avoid lymphedema. But at the same time, as much as we can be proactive, in terms of making patients aware of the different exercises and compression sleeves and those sorts of things that they can have, even that are safe to use during treatment. I definitely collaborate with my physical therapy colleagues to try to make sure they're part of the treatment team very early on.
I think those are great recommendations, because lymphedema is a gift that keeps on giving, and it's not a gift that you want. So once that has that onset, it's really hard to manage. So I think that's a excellent point for prevention. I think in light of time, we're going to kind of zip through just a couple other concepts. The one is that this patient, and what we should be offering all patients, that with a single syndrome testing is more comprehensive genetic testing, and the fact that this patient has breast cancer, a family history of breast and colon cancer, now puts her at elevated risk by finding out she has a CHEK2 mutation. So she requires more intensive screening for both breast and colorectal cancer, and offering her family cascade testing through a high-risk clinic or through your office. I think the last thing we wanted to focus on is just the cost of cancer care. And I think this is an interesting slide off the Office of Cancer Survivorship's website, showing that we used to always think about cancer care as being most expensive during acute or adjuvant therapy, or even end of life. But because we are really extending survivorship, both patients living with and through their cancer, we now see the most expensive sort of phase of cancer care as being survivorship. And that financial toxicity piece really impacting our patients. As Mayra alluded to earlier, whether it's copays, whether it's imaging that we recommend, I think that this is a really important factor, and the use of financial counselors and financial resources, and in light of COVID, has really come to light this year. Anything that you all would like to add in regards to financial toxicity from your vantage point, or maybe some suggestions in dealing with some of those longer term issues of financial toxicity?
I just want to say that there has been studies and there is evidence that financial toxicity can impact the quality of life and the survivorship of a patient, whether it is because they get less quality care, whatever, there's a slew of things that can contribute to that, but it does impact survivorship. You can have early demise just from the financial toxicity alone. So, and there is evidence.
Absolutely. And I think that this is this is a recent article that just came out kind of highlighting, Mayra, what you said, and the importance of really bringing that. And once again, as we've talked about tonight, setting that expectation, normalizing that discussion. These are all important factors as we counsel, educate, and support our patients through their journey. And as we've gone through this very quick and rapid journey, it didn't seem so fast on slides, but now we're kind of to the end of our story, looking at the experience that, a typical patient in our practice would experience, and the need to really have this comprehensive whole patient care. I'd kind of like to end our discussion hearing from each of our panelists sort of about what would your take home be from really helping our participants and viewers tonight understand the importance of survivorship and bringing that home and to the clinic and helping us care for our patients. So Dr. Mirabeau, why don't we start with you?
I mean, I think I've learned a lot listening to my colleagues here kind of talk about some of the different tools in their toolkit to manage some of the different side effects. So, maintaining an open dialogue, not just with our patients, but with our collaborators in managing these patients. And also, I definitely was taking some screen grabs, especially of some of Dr. Rosas's tips to share with patients. I think probably we can all be better about kind of having some written materials that kind of walk through the pathways and augment our survivorship care plans for our patients, because it is a lot to take in any given visit, and it's an ongoing journey.
Great. And Mayra, how about you?
Yes, I agree totally. You need to start from the very first visit, preparing them for the survivorship, because it is a lot to throw at them. At what point, where the idea of the survivorship care plan and stuff was so that other providers could be informed and stuff like that, but it is so much more, and it's of so much benefit to the patient and yourself as a provider to prepare them and to handle the issues that come with being a survivor.
Absolutely. And Dr. Rojas, what would you like to add to our discussion?
Yeah, I would just like to echo my colleagues here, everything that they've said about setting expectations, having an open dialogue, preparing patients, but also I'd like to encourage, other programs to consider having, with regards to the sexual side effects, obviously that's like my wheelhouse, but those conversations can be so long, and it's so intimidating to have those conversations in the busy clinic because we're moving so quickly and have so much to cover. Think about building a program or bringing someone in that could just be the sole purpose of that program. I found the clinic space, and started to market and really putting in the time to kind of make it separate. And then you have an easy referral and you have an easy resource for patients, maybe even within your own institution. Either that or collaborating with someone from the outside who's going to be your point person. Like, okay, I'm going to send you my breast cancer patients who are having all these problems. Let them be the expert, but you can just reassure them that you have a resource for them.
So I think, the other thing I'd like to add to that is if you don't ask about it, it doesn't mean it's not an issue. And so the important part we've heard tonight is really that open dialogue, the setting expectations, having those resources. It doesn't have to be, right there in your backyard, but you have to have resources available for our patients. And I would encourage everyone to sort of evaluate what tools are in your toolbox, what tools are missing, which tools need some sharpening, and kind of how do you want to fill in those gaps. So we want to thank you for your time. We want to thank our wonderful panelists. I think all of us learned from each other so well, and I appreciate their time and your time. And please feel free to put any questions you have or comments in the chat box, and we will respond to those. And we just want everyone to stay well, and thank you again for your time.
Thank you.
Thank you.